This is Facts from the Frontlines, St. Michael's Hospital Foundation's inaugural COVID-19 podcast series, where our world-leading experts provide the knowledge you need to keep you safe and informed.
Hello, everyone. My name is Bob Howard, and I'm here in the St. Michael's Hospital Foundation with Dr. Thomas Ungar, who is the Chief of Psychiatry at St. Michael's Hospital, which is, as you know, part of Unity Health Toronto. Tom's here to talk about mental health during these difficult times, and I don't think I need to tell everybody, but just to set the interview up, we have a worldwide pandemic with lots of unknowns. It's hit Toronto, and we're really not sure where this is going. We know there's huge economic fallout because of this, and we actually don't know where that's going. Many people are self-quarantining. They're cut off from their family, from their friends, from work colleagues. So not a stretch to suggest that there's anxiety out there and maybe even fear. So Tom, as Chief of Psychiatry, as somebody who thinks and works in this space, what advice do you have for the general public who may be in this, experiencing a lot of these emotions, fear, anxiety, obviously impacting negatively on their mental health? What advice do you have for them at this time?
Yeah, hi, Bob. Thanks. Great to be here with you. That's a big question. There's so much advice and things we can talk about. I think the main simple message that I tell myself, and I'm telling everyone, my friends, family, people who ask, is that anxiety and worry is normal. It's to be expected. It can be a good thing. It's a normal part of life experience. Life comes with worry. The trick is to keep the worry in keeping with the reality of what's going on outside of you. So we've got a serious concern that we all have to take heed of. We're social distancing, or really the better word is physical distancing. You want social connectedness. You want physical distance. The government just corrected that yesterday, by the way, because those of us in the world of mental illness stigma, we don't want to distance from each other. We want to physically not allow transmission. So you want physical space, but stay socially connected on the phone, virtually if you do Zoom or any of these other FaceTimes or whatever. So somehow if you have the luxury of staying socially connected, that's great. So we're all going to be worried. It's just the worry's got to be reasonable in keeping with it. What I'm telling some people to do is when they see the nightly news, which is the only one I watch, I don't keep up all day long because I'll go crazy, wacky myself in a normal, healthy way with the anxiety, is that I look at the number of recovered, not just the number of new cases, the bad news, but the balancing reasonable news that a lot of people are recovering as well. So I'm worried, I'm concerned, but it's not this continual, incremental, off to the moon bad thing that's going to go on. It will plateau and people will get better. So the worry has to be in keeping with the real threat. And it's a real threat. So I don't want to undermine it, but we can catastrophize to infinity if we don't catch ourselves. So that's what I try to tell myself every day.
Do you think that the advice should be different if somebody's dealing with a child, a teenager, and teenagers may be a special group because of their need to get together with their friends, and this is challenging them, or an elder? Would you change that advice in any way, or any special advice for any of those different segments?
Yeah, so the general principles are the same. I have three kids, two are young adults, one I would still call a late teenager. So I understand those challenges. Again, it seems like from what we're hearing, it's more the older age populations are particularly vulnerable. So again, in keeping with the real risk, it's that group I would worry a little more about and try and protect a little more if possible. But this presents a limit to our control. We can do our best, but we can't do everything. So I don't think the advice changes. The main thing is younger people, adolescents think they're invincible anyhow and omnipotent. That's a challenge because as much as they agree with me what I tell them to do, I know they're probably not following my advice. So that's a real challenge. So trying to be a bit more of an annoying, remind them to wash their hands when they come in the house or wipe down that basketball that say they've been playing alone, but I don't think they really have been, but we'll see. Younger kids, that's also an understandable concern. We all want to protect. They seem to be not, in the evidence, not getting as unwell, but I would just do the same advice as for everybody. You have to live and function. Again, we're physical distancing. We're not each in isolation as though we're all each individually infected at the moment. And there's a bit of a distinction between that. So I don't think they're making that that difference. And also, it's everything we're told, they're 99 something % sure this is droplet transmission. You have to touch the liquid from another human and get that in your body. It's not just floating around in the air. So if you keep a few feet away, you can go outside for a walk. You can sit in your front or back porch if you have one, or on your balcony. It's that physical closeness that's the risk. So we're not each in this unbelievable catastrophic transmission just by existing. It's the physical distancing that. So trying to keep your behaviors and your worries in keeping with the reality. But that's hard to do because, the worry system kicks in. It's like your car alarm. Once it goes off, it goes off. It's not incrementally deciding what the threat is. It just says at a certain point, I'm in a threat, my heart's racing, breathing fast, I'm feeling nervous. And I've got a bit of that, but not panic. But that you have to manage and just try to identify and say, okay, it's okay to be worried. We should be worried. It's just try and do what you can within the worry. And that's okay.
Because one of the challenges out there is misinformation that is often, I think, put out to actually alarm and I guess trying to be careful not to go to those untrustworthy sites where that might exist.
And that's huge right now. That's actually gets me personally annoyed. I don't tell people, of course, but so I get pretty exhausted with all the questions trying to repeat the same thing. I would check the Good Health Canada website, your Good Hospital website, or government website. I try to stay off social media. I'm not on my Twitter, even though I'm on it maybe for 2 minutes a day. I'm not scanning things. I hear from my family members and my young adult kids some of the wacky stuff coming out, and I'm just not paying attention. I encourage you to limit your time. Once you know what you need to do, you don't need to know anymore. Just know what you need to do and then kind of distract yourself or find other activities, because knowing more by the second is just going to make you really uncomfortable.
So, Tom, if there was somebody we're all sort of monitoring our families and trying to keep an eye on folks. Are there any signs, sort of mental health deterioration, like that somebody's really not coping well? I mean, what would we look for if that might be the case?
Yeah. So I'm going to answer that. I'm going to start by talking about mental health as opposed to mental illness. Just like you have physical health. So in this time, if you're at home, try and keep your physical health going. You try to go for a walk, exercise indoors, do what you can because you're not allowed to go elsewhere for your physical health. Good mental health habits, trying to get reasonable sleep, trying not to overindulge in substances or nice wine or whatever I might want to do, keeping socially connected a bit with people. Those are just good mental health habits to protect. Eating reasonably, sleeping reasonably, as opposed to drifting into mental illness. So having some worry, waking up once or twice a night now more than you might have, that's not uncommon. That's part of normal worry. If someone is really not sleeping regularly, if they're obsessing and can't stop all day, if they're starting to get these panic attacks when this alarm system in your body isn't just worried but goes off, and for half an hour you think you're having a heart attack, you can't breathe, you're getting these heart palpitations and sweating, you just can't eat at all, not just a lower appetite. Those are signs of starting to change. And if those keep going after a couple of weeks, you get really down, nothing interests you, and you're really starting to lose it with the catastrophic thinking, those are hints that you might be going beyond the normal worry, and there should be significant worry here, but beyond that into panic, depression, in drifting into the edge of mental illness territory, not just good mental health territory.
So what would you recommend one do if you thought one of your family members or yourself were kind of there? What in this environment can you do?
Yeah, so you can, again, try to remind yourself those habits, cut down the social media, try to talk to, if you have supports or family members on phone or in person, cut down the substances if you're using too many of them. That's just a healthy start, get some sleep. You can reach out to your primary care provider if you're lucky enough to have one. Most of them are doing virtual or telephone appointments. The government has enabled that and facilitated that, something that we didn't have before. I don't think we're going back from that, by the way, because that's just a great thing to have anyway. You can reach out to Telehealth Ontario or any online providers. Some people are reaching out to their community support groups, how's it work? That's a start to talk to somebody. If you can't do it alone, have them tell a friend or family member to do it on their behalf or support them to do that. And that's a way to start going up the ladder of getting a little bit of care or concern. If you're really unwell, someone's really having trouble, we're still providing care. Emergency room's open. If you need to come, we're still doing that. That hasn't stopped. It's just we're trying to minimize that or keep people in other safer places of care where possible.
So that leads into the next question, which is how are you as a psychiatrist working in a tertiary care hospital with following a number of patients, some of which have persistent severe problems? How are you functioning now in this new world?
Yeah, so I'm coming to work every day like I always did. It's amazing. So for the outpatient, or what we call ambulatory work, where you can get away with it, which is a surprisingly large amount of some of what we do, we're doing it over the telephone or on virtual care with a video camera on your computer. And that's going quite well. We can do a lot. We're getting pharmacy numbers and we're faxing or phoning that in. So we're continuing to provide that care. For some of our most unwell people with severe mental illness and mental health problems in the community, I work in one of those clinics up in our Regent Park for first episode psychosis, or our focus teams and sort of community treatment teams. Our workers continue to go out to the community. Our doctors will go out if needed, or we are doing the virtual care, phone prescriptions. We're even encouraging some of the workers to just click on their phones if they're with the client, or the clients, that we can see them and talk to them out in the community and continue that bridge for care. Our inpatient unit continues. We have 34 inpatient beds that we have doctors every day working. We have to continue that service, so we're working on that. We provide consultation services to all our medical surgical floors. In our hospital, because of the population we serve, we provide medical, surgical, and trauma care. A portion of our patients that we see are also our local community with our homeless, marginalized population, most of whom are suffering from mental illness and addiction issues. So we are continuing to do our consultation services along with our medical and surgical colleagues throughout the hospital, going around on the wards, seeing people where needed. So all that activity continues. We cover the emergency room. We were just down there this morning looking for alternative spaces if we have to make sure we're using the best efficient use of space to free up our emerge providers for people who need breathing machines and things like that. So we continue at work.
What about your colleagues who are in the same space as you, are psychologists, social workers, counselors? Have they all moved to sort of telehealth kind of model, or do you have any insights into what they're doing?
Yeah, I think the vast majority are doing that. People, even some of our staff who are maybe social workers, we're encouraging them to work from home. We're able to connect with people virtually. But if somebody really needs to be seen in person, I think they're all still seeing people in person. That's a smaller group who actually has to be seen direct live, and you just try to keep, you screen them, make sure no one's actively sick, try and sit at least 2 meters away. So a little bit of that's continuing, but most people have really done the physical distancing, but maintain the clinical care as much as possible. So again, physical distancing, social connectedness is the term I like, and that's continuing all the other allied health professions as best I'm aware of.
So one of the whole telehealth thing, there's something called the Ontario Telehealth Network, which has been around for quite a while now, and it allows, I think, mainly physicians that use it to provide care, sort of telehealth model, to the north. So, distance is a huge issue for the north. So there is some experience providing, and I think the psychiatry group has actually done that, because there aren't psychiatrists in small little communities that are hundreds of miles away. So there is some experience with this. And I just wondered, is there any data or evidence about how well that actually works as opposed to face-to-face care?
Yeah, there's quite a good literature on telemedicine, and amazingly, it does really well. You can do most, not all, but most of what you can do. In our profession, if you can see the person's face, that's very helpful. You get a sense of their affect, their expression, and their body movement, and their hygiene, and possibly a bit of their surrounding. So that's additional clinical information for us. But you can do an awful lot quite effectively. I'd say you can get about 80%, 85% done virtually if you're set up properly with the tools and enablers to do that. We have a few of our physicians who actually do participate in the going up north to Nunavut and other areas like that to provide care for 1 or 2 weeks at a time. Is the nature of the providers we have here at St. Michael's Unity Health. So you can do quite a lot. And it's interesting, the OTN network that you referred to is the one that's most secure and has been most set up, and we're all on it, and those who aren't are signing up rapidly. It's a great secure network. It's just a bit more administratively cumbersome to get on and use than some of the ones that everyone else is using, like FaceTime or Zoom or all these other things. But again, because of the urgency and what's happening, they've given us leeway to just get a patient's consent to say, yes, you can use that even though it's not totally secure. We just write one sentence, gave verbal consent, and then we can use any means, any of those even unsecure methods. And I think that's great given the rapidity of how this kicked in. So I'm doing all of that, and it's going really quite remarkably well.
So I guess for me, the answer is that it's reassuring. This actually works. We have some experience with this, with telehealth, and the fact that we're, being forced to move there, even, it's not hundreds of miles, it's just a short distance, but we have to stay more than 6 feet. So we're moving to this model. People shouldn't feel like this is grossly inferior care.
No, not at all. It's actually going to be great. I shouldn't say this, but I can do most of what I do like that. So it's going to create a real rethink after this is over about how we deliver care, because it's just so much more efficient. It's so friendly for the patients. You don't have to drive and park. It's actually really quite remarkable. I don't think there's any going back from this part of it. The cat's out of the bag.
Yeah. And I guess one of the advantages, you get to actually see them potentially in their home, which gives you a little more information that you wouldn't have any sense for what that might look like in your office, right?
Yeah, if they want to show that, depending where they are, it doesn't hurt to have a bit of a sense of that. It's like doing a home visit.
Doing a home visit.
Yeah.
So you've already sort of said this, but I guess you do care for a number of people with severe persistent mental illness. And that is always a challenge at the best of times. Not an easy population, but particularly challenging now given the issue of social distancing. So how are you coping with that?
Yeah, that's a huge issue for us right now. And I'm very concerned about that because so many of the things we're asking people to do require their having the cognitive capacity, the wherewithal to participate in the physical distancing, have the physical space to sleep apart, 6 feet apart from somebody, use a separate washroom, have access to water to wash hands, as well as have the wherewithal to be able to do that self-attestation screening before you go somewhere that you're well. Some of the people we serve don't have those abilities. It's not a fault of their own. It's not a moral weakness. It's a feature of their brain condition and their severe mental health condition. So we're very concerned. How do we incorporate that thinking into our policies and our safety procedures? We're thinking it through a little bit. We've had in place before. Some we're being very creative as we go. But I do think it's going to become an increasing concern because of the resources to do that, both physical resources, person power, personal protective equipment. We need to do that. And even the legislation. This is going to become a public health legislation issue because we're always balancing civil liberties from personal safety and public safety. And this is a new level of it. We have, this is something different. So I think that's going to evolve, but because I am very concerned that they are a very high at-risk population. So we participate. We have our focus team go out into the community for that's a flexible, assertive community treatment with workers and a physician. Physicians in the background often that serve that population daily. They check on them, deliver medications. So we continue to do that. We participate and are aligned with a group called Inner City Health Associates. We credential their physicians, and they go into all the shelters. They have about 2/3 family physicians, 1/3 psychiatrists, and we go and try to serve that population. That's challenging because it depends if the shelters are open or those places in the parks or where they exist, if we can find them. So we're struggling and developing policy on the fly, but that is an area of major concern for us.
And I guess just to take that one step further, there's a particularly difficult group that's part of this, which is the homeless group. A significant proportion of those folks have severe persistent mental illness, and that's even a more special challenge.
Absolutely, because some who may be homeless but maybe not as mentally unwell can try and participate in some of the things to stay well, and when they're mentally unwell, they just can't organize themselves as well. So it's a really high at-risk population, and requires some really interesting different design thinking solutions to how we serve them, planning for that as part of the strategy.
Tom, I wonder if you have one uplifting story that you could share with us today that's occurred recently as part of this crisis.
Yeah, I'm trying to keep that in mind, and I tried to remind myself we're going to have our winter holiday party in December, so to also think about booking a date, but I don't know if my colleagues wanted to hear that right now. I'm just trying to do some self-talk that there will be a time after this. Because having worked through the SARS crisis in 2003, SARS-1 and SARS-2, I was at a hospital that had that, and I had to be in self-isolation just preventatively like everybody else. It's like a deja vu, only on a different scale because the society's involved. There will be a time after this. I'm actually making a list. All the little things that we were working on to try to improve, all the little funny little strangeness in our procedures and policies that took a lot of administrative meetings and a little bit of dithering and maybe weren't getting there yet, are suddenly being solved really quickly, and it's highlighting every one of those. So I think it's going to lead to a much more efficient, much better system after, because we're solving them on the fly, and it's going to point out where we had points of weakness. The virtual care, for example, I don't think there's any going back. I think the public's going to demand that, and that's going to be a really good thing. In my own program, I think this is a personal plea, we're a little undersized for the job we're doing. So I think it's going to just help me point out, and I think the organization realized that the population we serve doesn't just exist in the psychiatry department. They know that, but they're throughout the organization as a significant portion. So really getting the supports, as well as I think it's going to highlight the idea that we have some ambulatory space in the hospital. We do some outreach to the community, but we maybe don't have locations to do this in the community so that we don't have to bring infection risk in, but continue to deliver the care we serve. So I think a lot of our structural needs, process flows are going to be highlighted, and that'll help us identify solutions and streamline to just the most important things and really get away from some of the silliness that we were just talking about, maybe not acting on as quickly as we could have.
Thanks. A special thank you for taking the time today, and a huge thank you to you and your staff for doing what you do for our patients. Be well.
Thank you.
And that's it for this episode of Facts from the Frontlines. To stay up to date and access all of our episodes, visit stmichaelsfoundation.com/COVID-19.